Good morning, good afternoon, good evening all. A very warm welcome on behalf of the IAPB events team. We are very much looking forward to supporting you today with the Advocacy to Action workshop, Community Voices in Advocacy. I am now delighted to hand over to Jess to welcome you to the workshop. Thank you.
Thank you, Ros, and welcome everyone to our fifth and penultimate session of Advocacy to Action on Community Voices in Advocacy. I have the very easy job today of moderating the session. Easy because today we at IAPB are in listening mode. This workshop is an opportunity to hear from all of you on how we can better engage and include community and patient voices in our collective advocacy efforts. As Ross said, we'll be spending most of today in breakout rooms, and we have a very impressive group of presenters and facilitators to lead those discussions, who I will introduce shortly. But before I do, we'd like to find out where everyone is joining from today. So can I ask the team to put up our first Slido poll? And we'd just like you to add into the poll where you're joining from. So we have people from London, where I'm dialing in from today. Nigeria, fantastic. Welcome. Switzerland. Philippines, Nepal, now we're getting lots of different places come in. India, the US, Malaysia, Australia. And I think that the bigger the name of the place, the more people we have joining from that particular location. Vietnam, Pakistan. As ever with Advocacy to Action, we have such a diverse group of people joining from all over the world, which is fantastic. Belgium, the Netherlands, Zambia, a few other places in the UK I see, Southampton, Nottingham. That's great. Well, we'll bring that poll down. Oh, a few more people from Belgium. Well, really fantastic to see so many different people joining today. So before we start the main discussion, I think it's really important for all of us to be clear about why we should include community voices in our advocacy and what do we actually mean when we refer to community voices. So we're going to start off with just a short group exercise. We're going to break you out into sort of groups of 5 or so to discuss these 2 questions. These groups will be completely at random. And so can I ask you within your groups to nominate a scribe who will then be responsible for reporting back to the main session. So you'll have 10 minutes on these 2 questions. And just a reminder, the questions are: why include community voices in advocacy, and who do we mean when we refer to community voices? We'll bring those, should bring those up on the screen. There we go. So again, Ros and the team, can I ask everybody to be broken out into the groups?
Thank you, Jess. As Jess has explained, in a moment you will move into randomly assigned breakout rooms of up to 5 attendees for the first small group activity of the workshop. Once you're in your breakout room, please turn on your video using the button on the left-hand corner. It really does help for engagement and interactivity. Also, change your view to gallery view so you can see everyone in the room. Do allow a couple of minutes to introduce yourselves and agree who will be your rapporteur to capture notes. We will ask the rapporteurs to add key points to Slido when you report back after the breakout. Also take a note of your breakout rooms should you become disconnected so we can pop you back in. And if you need assistance, ask for help and we will send a message to the main room. There will be a 2-minute reminder at 8 minutes and then a 60 seconds warning before you automatically return to the main room. And we have posted the 2 questions in the chat as a reminder. Good luck, everyone.
Thank you, and welcome back everyone. And it's nice because now I can see on the top of my screen, I can see everybody's videos on, some familiar faces and some new faces. So I hope you had a good first discussion. What we're going to do now is we're going to ask you to feedback. So again, hopefully you nominated a scribe, someone who kept a note of your discussions, but we're going to do it through Slido again. So we're going to ask you to put your responses to the first question, which was, why include community voices in our advocacy engagement plans and strategies? And if you could just type into the Slido some of the kind of reasons that you came up with. Doesn't have to be particularly long, they can be sort of short one-word answers to build consensus. Absolutely. I think that's really important, and particularly important reason as to why you need to do it from the very beginning of your advocacy efforts. They are the beneficiaries, yes, to reduce disparity, to make the interventions culturally acceptable. As the beneficiaries, their voices are powerful, ambassadorship, empowerment. To engage everyone, to gain insights. And all of this, I think, really speaks to the heart of the agenda that we're advocating for, because both universal health coverage and integrated people-centred eye care are underpinned, by the idea that health systems and indeed eye care systems belong to the individuals, the people that they serve. Some more answers coming in: to identify the core need, to build ownership, to ensure the durability of programs. And I think we've all recognized, particularly since COVID-19, how important it is to build health systems that are responsive to the reality of people's lives. To keep government in check in relation to goals, absolutely, that can be a real mechanism to ensure accountability. So it's a huge amount there. And of course, ownership, really standing out and bringing all of these key elements together. Cultural respect. I think I was anticipating that, we might have a handful of reasons come back, and actually looking at this screen, it's so striking because there's so much there of why this is a really important piece within any advocacy plan and strategy, but also within any program that we're building around eye care. So we will keep all of that information. Thank you very much. Can I now ask you to report back on the second question, which is, who do we mean when we refer to community voice?
Hello, I think what we...
Yes, hi, sorry, can hear somebody.
Yeah, this is Michael.
Hi, Michael.
Fine, how are you?
Good,
good. I'm trying to explain that what do we mean as community voices. It's like, as we mentioned before, we include the stakeholders, the teachers, the chiefs, the community health workers already in existing health centers in connection with eye care in the area that maybe one is operating in.
I think that's absolutely right, Michael, and that's very much what people are writing in at the moment on the screen that we see here. We see community leaders, we see local service providers, family members, carers, patients, general people. I mean, I think here you know, there are no wrong answers. I mean, we're all members of our community, and especially in eye care, you know, we all may experience an eye condition within our lifetime. So we're all patients in that respect. And I think it's great to see that represented in what we have here on the screen today. So just give people a few more minutes to input their answers. Eye care professionals, children, parents, teachers, really important parts of the community. Community chiefs, funders. You know, what we're really talking about is the whole population, community, and civil society. Great, thank you very much. I think that was definitely a very rich discussion and really useful to help inform the next part of our session, because, you know, for all of this to happen, for us to include these voices within our advocacy, we need to create the right enabling environment, and we need to create a space which allows for meaningful dialogue, for debate, and really serves to amplify those voices that we see on the screen there. So I'm just going to introduce briefly the next session, because that's exactly what we're going to discuss. We're going to break you out into 4 groups to discuss 4 questions. And can I ask our team to bring those 4 questions onto the screen, just on the holding slides? There we go. So the 4 questions that we will be discussing is, how do we best engage patient and consumer voices in developing our advocacy strategies? How do we harness the power of consumer and patient insights? How do we engage community voices in people-centred eye care? And how might patient, consumer, community voices be harnessed as agents in implementing advocacy action? Each group will tackle one of those questions for about 20 minutes, and then we will move you to a second breakout room to discuss one of the other questions. So you'll each get to discuss 2 of those questions that you see there on the screen. But don't worry, you will be guided throughout by our wonderful presenters and facilitators in each of the rooms. So let me briefly introduce our speakers today. And I should say, my introduction will do none of them justice. So I really do encourage all of you to have a look at their biographies on the IAPB website. So our presenters today are Avril Daly, who is the CEO of the patient-led global umbrella organisation Retina International. Avril has worked in health policy for rare and common eye diseases since 2000 and was CEO of the Irish NGO Fighting Blindness for 8 years. So it's great to have Avril with us here today. Our next speaker is Michelle Savanovic, who is the Director of Global Advocacy Ophthalmology at Bayer. Many of you will know Michelle through her groundbreaking work to examine the impact of diabetes and its associated eye disease complications from the perspective of people living with diabetes through the Diabetic Retinopathy Barometer. So welcome, Michelle. Next, we have Ravindra Srikaya, who's the Regional Programme Manager at the Seva Foundation and who has managed and led 3 different organisations as country director, focusing on everything from youth, education to health. So welcome. And finally, we have Megan Webber, who's the co-founder of the Know the Glow Foundation, which she launched after her son, Benjamin, was diagnosed with Coats disease in 2009. So there are fantastic presenters that we have today. In each of the rooms, they will also be joined by our facilitators. And I'll just briefly introduce those people, our facilitators. Again, many of them I'm sure will be known to you. So we have Iris van der Brand, who's the Global Patient Partnership Lead for Ophthalmology at Roche. We have Brandon Atong, who's the head of public policy and advocacy at the Fred Hollows Foundation. And we have Aaron Kumar Gali, who's the executive director of Africa operations at Advocacy Associates. So, and we will also have various members of the IPB team in those breakout rooms too. So I'm going to hand over now to Roz to put you into the breakout sessions.
Thank you, Jess. In a moment, as Jess was explaining, we will move you into 4 randomly assigned breakout rooms for further discussion for the first of 2 20-minute breakout discussions on different topics. Again, please turn on your video using the button on the left-hand corner and change your view to gallery view so you can see everyone in the room. Your discussion will open with a 5-minute presentation and 15 minutes facilitated discussion. There will be a reminder at 18 minutes and then a 60-second warning before your presenter and facilitator will rotate round to the next breakout group. You will remain in the same room for the full 40 minutes. Again, do take a note of your breakout room facilitator name, as should you become disconnected at this point, we can use this information to add you back into the correct breakout room. And please ask for assistance. Please click on the Ask for Help, which sends a message to the main room. There will be a 60-second warning at the end of the 2 breakout discussions before you automatically return to the main room. Thank you. Enjoy.
Thank you. And it's lovely to meet you all. This morning, really, this afternoon or this evening, depending on where you are, I just wanted to talk to you about public patient engagement in policy action and development in the context of health and research. And that's an area that I've worked in for a number of years in the context of the retina. So we'll just move on to the next slide. So really, PPI, as it's known, it's been around for quite some time. So public and civil society engagement in the development of research is something that is not new. And it has really been, I suppose, promoted mostly by patient organizations involved with kind of rare conditions where there was not an awful lot known about their condition. And so therefore knowledge of research and knowledge of clinicians enabled patients to really say, you know, maybe there's something we can do here. And in fact, have the patients influence the researchers and clinicians to look at a specific condition, and really it's gone from there. We started researching retinal disease in 1971, and you know, so it takes that long, and we've seen a lot of progress in the past 50 years, particularly in the past 15 years, in the context of treatments for age-related retinal diseases and also inherited retinal diseases. A lot of that started by patients. So just to say that that is not a new thing, but now the difference is there's a name for it, which is PPI. And then there is a prerequisite really for a lot of research, statutory research now, in the context of not only research in medical research and lab-based research, but also social research, to really have the patients fully engaged in the process from the concept to delivery. And that's something that is given weight and can help people when they're going for their applications for funding. So next slide, Iris, please. So what we apply is what we call the listen, learn and lead approach. We know that civil society and patients are seeking and are actually engaged in a number of committees that are at state level. And these committees can impact the future of society at large. It's accepted that using real-world evidence is really critical to the development of health policies that can alleviate distress and improve health outcomes. So listening to the need of a population, you know, and their lived experience can really allow legislators to learn more about what the gap in legislation means on a day-to-day basis to the person who's delivering the healthcare, but also the person who's receiving the healthcare. So if there's a gap in policy, it can affect us on a day-to-day basis. And, you know, if we can really listen to that and apply that knowledge to the development of advocacy campaigns, we can really lead the change as a collective. So, you know, working in consensus, we can do that. You know, we can use focus groups, we can use surveys, you know, to understand the need of a particular consumer group, as has been done by other industries throughout history and in other areas, for example, IT and other, areas of business to business. They don't just sit there and assume that they know what somebody's going to need. They actually get engaged and involved and ask the questions, and that leads to better outcomes. And we see that in IT all of the time. So if anything, we should be applying that practice to health, which is clearly one of the areas of the greatest importance, as we all know, and because we work in this space, but as we've seen more recently, why health is really so critical. So move to the next slide. So what we would ask is that you and all of us, that we pause and we consider a few questions, and we say, well, what are we trying to achieve? So if you're a clinician, if you're a medical professional, a researcher, and you have a project that you're trying to move forward, you say, well, what am I trying to achieve here? And then reflect on, who you need to engage. Is it a patient or a civil society group with a particular experience? What's in it for them? Why are they involved? What do they want to get from your project? And what you'll find often is they just want to support you and make sure that you have the information to make it easier for you to do the work that you want to do. That's what they want to achieve in all of this. But you need to consider also what the insight and information that they can provide, how that can, do you already have access to this? What kind of, it's basically asking the question of what information do you really need? And then you also have to ask yourself, are you the expert? And open, your mind and the way in which you work to getting the perspective of others. And that's really what this is all about, collaboration. And then learning how to apply that information to the work that you're doing in order to benefit all, bearing in mind that it's likely that you will get a lot more information than you probably bargained for. And that could be a very positive thing in influencing your future activities as well. And you're also building relationships with communities where you can just pick up the phone or email somebody, and that relationship becomes a very solid one that will go on, to help you as you move forward. So the next slide, please, Ali. Thank you. So what we would also say is, get it right from the beginning. In our experience, and as you will all know, medical research is a long and a winding road. There's an awful lot to it. When I would have started years ago in this space in policy and advocacy around research, we really were just, working with researchers and working with clinicians to say, we have to sit in front of government and say, we have a population that has an unmet need here. Please fund our research. It was as simple as that. And now as we have progressed and as we have moved on, we need to apply all of this collaboration to advocacy, not just for the funding, but also, to look at how do we improve clinical trial designs by listening to the patient. How do we really look at the regulatory space? Is that fit for purpose for ophthalmology for the conditions that we are concerned with? Also in the health technology assessment, where they look at value and sort of say, well, are they applying the right metrics to understand what value is to that patient cohort or to that particular civil society group? And how can we influence that? And then the development of care pathways, because, research is moving at such a pace and innovation is moving at such a pace. And certainly in the past 15 years, we would be in a situation where now we have new treatments and new therapies for diseases that, didn't have treatments before. And we have to start to look at developing care pathways with the professionals in order to ensure that they are fit for purpose and appropriate for the patients, but also that we can say to governments, by funding all of this and supporting all of this, then, we can horizon scan, we can look to what the future is, and we can really start to prepare for the delivery of therapies into the future, and also plan how we can develop our healthcare system in order to be able to really address these issues. So, these are all the areas of advocacy that we need to work on. What we need to do ultimately is prioritize those. So to conclude, really, what we would say to researchers is, this is not a new thing. Patient groups and civil society groups are here and willing to work with you. They are not trying to do your job for you. You're the expert as a scientist, as a medical professional. We're the experts as civil society. We can provide the real world experience, and we can really work together to ensure that what we're doing has benefit for all, and that it can be, that benefit is experienced faster. And ultimately, in our case, can be utilized to promote the prevention of unnecessary sight loss. And that's really what it's all about. So I'll leave it there.
Consider your methods. There's qualitative versus quantitative. Qualitative has values. They tell the human story. It tells you who is Sue and what is Sue's position and how is she going through this? What are the challenges she's facing? Or mother of a daughter who can't get glasses. Why are all the challenges facing? And ultimately it's resulting in poor grades. That tells the story, which policymakers will want to hear, but they don't make decisions based on Sue. We need to quantify those trends and really show the amplification of issues and how it's affecting their population, their voters. Consider the whole ecosystem. This is all of the people that are being affected. It's not just the patient. It's not just the doctor, the expert. It's also the person who cares with them, daily living, takes them to appointments. Maybe the health staff that's going and seeing them when they're getting scans. Maybe it's the transporter. And it depends on your local situation. Show a full picture because it can show real discrepancy. One example on the DR1, we asked the doctors and the patients what challenges to having your eyes screened annually to test for diabetic eye disease. The doctors blamed the patients and said it's because they have no education. They don't understand their condition. The patient said, it takes way too long for me to book an appointment at your office, like 6 months, and the fees are too high. I can't afford it. You see that disparity right there, and that's a simple thing that you can also try to work on. The fourth one is very quickly is also make it action oriented. Look for solutions when you're surveying or asking this community. You don't want to just highlight the issues. Nobody likes a complainer. You want to look for the opportunistic ways to improve care. And I give another example here. We asked doctors, patients, and staff what would be a list of opportunities. And one of the opportunity was that help with paying for parking at the office. Now, all of the patients said that that was the second most high opportunity that would help them in their day-to-day. 50% of the staff said that could help. None of the doctors said that could help. So really having that solutions, look, and then the docs, when they hear this, go, I would never thought that, but you can already do something with it. And the last, fifth and final, bring everyone in the community along the journey with you. Make sure you see the connections. It's not just an eye health issue. Perhaps it's an older person issue. As I mentioned, 1.3 million people living with that, being over the age of 65, corresponding with the larger number of diabetes patients. You think about broader policy context, decade of healthy aging, WHO's call when about vision health targets. Older people who have eye conditions have a loss of function, which has a loss of independence, which then means they're more likely to go into long-term care. This is unfortunate for all, and we don't want to see this regardless of what policy we are, if we're as the aging sector or the vision sector. So learn to work together and the community have a larger share of voice. And with that, I think I'm in the 5 minutes.
So welcome to our session, and I'm very happy that I'm happy to share my some of my experience, our experience in Sheva. So you can see more clearly when you listen to the community. This is what this bold and beautiful lady told us when she took us to the island. In the picture, you can see the island in the mighty big river, and she's nicknamed Sevika Ama. That actually means the Seva, the volunteer mother. And today I'm going to take you on a kind of virtual tour with this lady and share some of her experiences and how we reach out to the communities. So today, our title is how do we engage CSVs in people-centered eye care? So CSVs are called female community health volunteers in Nepal. So I'll be giving a lot of examples from Nepal. So I'll be talking about who are these FCSVs. And we'll talk about the SEVA model. We'll talk about why it's so important to listen to the voices of the communities and how do we link those voices to our advocacy. So I will be just briefly talking about all those things. So we have only 5 minutes for this presentation. I will just go quickly on that. So who are these FCSBs? So the FCSBs are the people who are the most trusted group in the community. They come from the same communities. They are health practitioners. They are trained. They have wealth of practical experience. They can speak local language. They can, they know the local culture, and they have excellent networks, and they are available almost all the time. And they are usually the members of the mothers group. So they are very well positioned to listen to the voices of the communities. So the model that we use in SEVA is we have taken out all those barriers. So there are lots of layers and barriers to reach out the communities. But in our model, we actually have introduced the youth coordinators, and through youth coordinators, through youth outreach people team, then we work with FCSBs and we reach out to the communities. So let me also explain a little bit about who are these youth coordinators. These youth coordinators are based in the field. They are highly motivated young people, and they are trained by our SEVA team and also by our partners. They are equipped with basic eye care skills, and they are mobile. So they don't stay in one place. They go from one village to another village. And this is the model that we use in our when we work with the youth team as well as our FCSBs. So I can explain more about that in our discussion forum. But basically this youth team creates awareness. So they do different activities, use different IEC materials, and they go to schools, they go to communities, they go to door and create awareness about eye care services. By that, they will generate demand. So many times they don't know about eye care services. So they generate demand, they link that to the service providers, then they actually link to our hospitals, to the vision centers, and they also ensure that there will be a quality service provided for them. If there are insurances, if there are surgeries, they also facilitate that sort of processes. And after that, they also make sure that there will be a follow-up service for the patients. So how we engage our FCSBs in the eye care? So remember, these eye care volunteers, they are not the real eye care volunteers. They are the female community health volunteers. So they are responsible for the whole healthcare services in the country. But we try to bring them on our side. We make them realize that eye care is very important part of the healthcare. We provide the basic training and exposures to our these FCSBs, and we collaborate with youth coordinators. So basically, we equip them, we engage them, and we empower them to work in the communities. So why we listen to the voices of the communities? These FCSBs are the best placed to listen to the voices of the communities, whereas SEVA and our team is best positioned for advocacies because we are based in the center. We have direct connection with our ministries and our donors and partners. So it's very easy for us to connect the community voices to those policymakers. And it is very important that these voices are linked for advocacy, because we want to make sure that it comes with unbiased nature. It is, and we collect those evidences, and we also make sure that it will be it's coming from a diverse section of our society, and also no one are excluded from our services. So coming back to our first slide. So when we were taken to this island, the FCSB, who is here, she said that the people in the village, they don't actually believe to the outsiders. Because many times people don't reach out to these people. They promise many things and they are not given service on that, and they were so reluctant to get services. So it was very difficult for us to reach out in the beginning. But when we actually brought these people to our programs, and our the young people and the FCSBs, when they work together with these people, and when they were brought to the hospital, they were so happy. Actually, they got the surgeries, and then we listened to them. And one of the big problem and one of the big barrier they told us was the economic barrier. And we heard them. We discussed about that. The young people, the youth team actually connected them to the free insurance policies of the government, and the government actually provided the free services later on. So these patients later became advocates and the champions for our programs. So these are some of the experience that I wanted to share with you all, and I think I'll stop here.
Hello, everyone. It's such an honor to be asked by the IAPB to present to you today, and especially to talk with you about a subject that is so near and dear to our hearts at Know the Glow, advocacy. My name is Megan Weber, and to better understand how advocacy turned into action for Know the Glow, I'll share a little bit of our history. This is my family 10 years ago now. I'm the mother of 3 children, but it's my second son, Benjamin, who led us down this particular journey. Ben was 5 years old when I began noticing this strange golden glow in photographs of his left eye. It was like a gold coin almost, and it wasn't in every photo. It was only in night photos typically, or photos around the holidays when we were in dimly lit rooms with the flash on. When on a trip with my sister, every photo she took of Ben showed that glow, and she remembered hearing on a TV show years prior that it could be a sign of cancer in the eye. She called and asked me to show the photos to my pediatrician just to be safe. I started poking around on the internet and saw quickly that retinoblastoma was cancer of the eye, and that if you missed your window, it could pass to the other eye or even the brain. I raced to the pediatrician, and when he looked at Ben's eyes, he saw nothing. But after seeing the photographs I showed him, he did send us on to a pediatric ophthalmologist for a thorough check. It was there when Ben's right eye was covered. His left eye could not see the letter E, the size of the full computer screen just a few feet away. My husband and I were shocked. He was 5 years old, fully verbal, not running into walls, rubbing his eyes, never complaining about his vision. How could he not see in that eye? The next room scared us even more. The scan of the mass in the interior of the eye, which is what was causing the glow to reflect back into the camera. It was believed to be retinoblastoma, cancer of the eye, and we were then sent immediately to Children's Hospital Los Angeles, where we were met by 2 doctors, Dr. Tom Lee and Dr. Lynn Murphy, experts in retinoblastoma and something I had not yet heard of, Coates disease, a disease where the blood vessels are leaking fluid into the eye, which is collecting and separating the retina over time. While we were in a daze as a family, these 2 doctors would then work to find Ben's diagnosis. And it was ultimately determined that Ben has advanced stage Coates disease. So while not cancer, Coates is another lifelong condition which can lead to the removal of the eye, if not caught in time. He's lost most of the vision in his left eye. He's been through multiple laser surgeries, patching programs, and is checked every 6 months. But he's managed through beautifully. And if you fast forward to Benjamin now, he's a teenager, senior in high school, getting ready to go off to college. He plays sports, he drives, He's never let his vision impairment stand in his way. But after his diagnosis, we were left with so many questions. Mainly, why did we not know that this glow was something to watch for? And what if it had been retinoblastoma and he'd lost his eye or even his life due to our lack of awareness? Working with the doctors, we came to learn about the more than 20 different vision conditions that the glow, leukocoria, can represent, and that the glow is often the only sign that there's an issue with the eye. When we learned that 80% of the time it's parents or family who first find the glow, and that 80% of the time childhood blindness is treatable or even preventable if caught in time, we knew we needed to take action. Advocacy began. Surrounded by friends and family, Know the Glow was born. An awareness campaign aimed at sharing the message of the dangers of the glow through our website, through PSAs that showed who helped first find their family's glow, and through a co-branded ad campaign. We hoped initially to find just one child in the US with either Coats disease or retinoblastoma. We did hear from families, lots of them, many passionate about sharing their stories, sharing the message, one mother even tattooing Know the Glow in a ribbon on her arm. We knew we were making an impact. We began hearing also from patients and families all over the world, sometimes from countries we'd never even heard of, asking to share their story or to start a chapter in their country, or to ask for help in finding answers for their children. One day when a Google alert showed an article about a childhood cancer awareness parade in Mumbai, we zoomed in and saw that not only were they borrowing our phrases for their handmade signs, but they'd even written Know the Glow on a few of them. We knew then that we could provide them with better materials to help create more awareness in their part of the world. Our global outreach program began. Our team of volunteers partnered with students and faculty from the University of Notre Dame, and we began to reach out to doctors and NGOs in other countries. Our creative media team developed infographics with short, simple messages and hopeful faces of children who would better reflect the countries we sought to engage. With local volunteers translating phrases and pictures which do speak 1,000 words, we hope to turn awareness into action and to reach out through social media and traditional marketing channels to build awareness abroad. We've come to develop now a process of creating campaigns in countries, first by meeting the families, meeting their doctors, the hospitals, the NGOs, learning about the country, their practices, their screening processes, and their outreach, connecting the dots, highlighting their work, and building bridges each step of the way. Everything we create, we give away freely. And as we've often said, you can't treat them if you can't find them. With Know the Glow, we hope to offer more ways, especially for doctors and NGOs, to do what they already do even better, hoping that through awareness, education, and early detection, we can help families find their way to local resources and stop these diseases in their tracks. Recognizing that the majority of visually impaired children live in Asia and Africa, and how large the challenge is there, and especially recognizing that around the world, the 0 to 5 age group is not only the most often overlooked for eye care and screening, but also the most urgent to find for diseases like retinoblastoma and Coats. We believe that the #1 way to impact childhood blindness is through early detection, and we know how imperative it is to advocate for those still waiting to be found. For every parent who reaches out to us, there are probably hundreds more who will not know how to find us, how to find answers, or even know what questions to ask. And we also know we can't do it alone. It does no good to alert people to a problem without having a plan in place to support them. And so by linking arms with other amazing, like-minded organizations, we hope to ensure that these children can find their way on a supported journey from the moment of glow detection to proper diagnosis and through treatment to aftercare. We're always looking to jointly build a bigger megaphone, to educate healthcare workers, medical students, and especially to empower families with information that can help them overcome their fear and prevent potentially devastating blindness and even needless loss of life, all through simple awareness. Together, we can help make the path straighter and shorter and the future much brighter for tomorrow's children. All through 3 little words, a photograph, and a team ready and willing to turn adversity into advocacy and advocacy into action. Thank you.
So we're now going to hear what you were all up to in your breakout group. So I'm going to ask our wonderful presenters and facilitators to report back to the main group their discussions. And so can we start with Avril and Iris? Your group was looking at how to engage patient and consumer voices in developing your advocacy strategy. What were the main themes that came up?
So Avril gave a very nice presentation on public patient involvement in medical and social research, and that it should be a multi-stakeholder consensus-driven approach, and then it can lead to very robust, lasting and life-changing policy actions. That is one of the themes that she talked about. And then there was some advice given on how to do that. We really need to listen, then learn and lead. So that's very important, because patients and civil society groups have very active roles now in developing policies. So there's a very big importance to really listen to those groups and then learn from them and then go lead. We also talked about real world evidence, that is critical to the development of health policies. And also there we need to listen to the needs of the populations, their lived experiences, so that we can learn from that and also then go leading when it comes to policy strategies. And then another methodology which I found very, very concrete and useful is the pause, reflect, apply methodology. So pause a little bit, what are you trying to achieve? And then try to understand where do you think a patient group will want to be involved, and what do you think that they want? So again, it goes all back to listening to the community and really including those insights in your work, getting it right from the start. And then, yeah, we concluded again that it's very important that the PPI, as we called it, that it's essential for success when it comes to policy work. So that was a little bit the summary of the presentation, and then we asked the people about their experiences with this work and also about their challenges. And there were some challenges, and it mostly came from the really local challenges. So people living in rural environments with not so easy, where it's not so easy to do the policy work because of a lot of environmental and societal challenges. So there was a question on how we can include the knowledge of the local people, and also how can we present this knowledge to the government. So that was one of the questions that we got. And there Avril gave a very nice answer that we really need to narrow down, and that we need to make to let the government see that it's not like a very narrow, non-detailed way of working, but that you really have to go down in the layers and try to understand what's important, not from a very broad perspective, but really going down into those layers. You really need to understand what is needed within the community, and then also go into consensus and starting from there. And then, yeah, I think that the whole listen to the community, learn and lead always came back. Also, when it comes to China, there was a question also on the challenges, that there is like a very long process when it comes to policy procedures and how we can really try to tackle them. And there was a very nice solution given, that first there was they've built a strategy on what evidence and how we are going to, what evidence we need, how we're going to gather the evidence, and then go with that evidence to local governments, and hopefully then the local governments go to the national government. So that was also one of the discussions we had.
That's great. So really working from the ground up to see that policy change. Well, it sounds like a fantastic discussion, and I think, you know, what's really come through there as you said, is the listening, but also, you know, building that in from the very start. And this is, you know, part of the reason that we've had this session and we've put it together in this way, because it's the very start of that listening process and starting to engage all of us into thinking about this when we're developing our advocacy strategy. And there's many more opportunities and steps that we need to take to start that listening process. Thank you, Iris. So let's move on now to our next group, which was led by Michelle.
Hi, thanks, Jess. Yeah, we had our 2 sessions as well. It was very engaging. It's good to hear the experiences of the participants that have undertaken such an approach of collecting and considering patient insights to affect change. Quickly, just following on the previous report back, I'll just touch on the presentation I gave, and I pretty much, there's 5 key takeaways that I wanted to instill from learnings from the DR Barometer 1.0 and new 2.0. And it's really make numbers relevant and establish the local situation and ensure inclusivity to not create a disproportionate side of the story. So you want to you have these large global numbers or even country numbers, but it's making the numbers reflect the community itself and ensuring that responses you get actually reach all of the community members in scope. So in my example, we did an online survey and we rolled it out in low-income countries and actually missed a whole portion of the population because they didn't have internet access. Second learning was kind of taking both qualitative and quantitative approaches when collecting data, because actually they both play a significant role. The qualitative gives you the trends and the human story behind it, really dive deeper into it, but you need the quantitative really then magnitude of the trends. And so that's what the policymakers will look to. A good story is a good story, but how often that story is played out in their community is more concerning, and they'll pick it up. Consider the whole ecosystem, and I think that was raised by the earlier presentation, and that it's really not just the patient or not just the expert. You have to look at the ecosystem within that patient goes through, or that person at risk goes through, and ensure we're taking insights from all sides. The fourth was make it action-oriented when trying to collect data and information and not just state the problem, but already start to think about solutions and quantifying. Do people find that a real good solution that might be low-hanging, but it might be the biggest impact? And I gave the example of compensating parking. People have to go through. And then fifth was bring others in the community alongside you. Consider it, I always say, like the beautiful mind, Russell Crowe. Really look at your ecosystem that you're living in. Who else has a stake in this topic? And I brought in the aging sector. So that could be another area you partner with, because they want to ensure that older people keep their vision, keep their function. You could partner with other non-eye organizations to share your story and build it. And in that, we then discussed kind of other approaches, challenges people had faced in these certain topics. And one came inclusivity. How do you ensure the appropriate demographics are being covered? And we had a nice, Yuda actually presented his grad study that he did in Afghanistan and faced a challenge that when he went to the village, the chief was like, you're not having a male doctor look at our female population. And then they kind of challenged back and said, well, you don't let your girls go to school, so where am I supposed to find a woman ophthalmologist in Afghanistan? And that didn't work so well, but instead they went and took a bigger call. What value that is going to bring to your village? You're actually going to get eye care services. You're going to get access to opportunities. And if you just are stuck on this one point, all of that will go away. And that came through a higher authority. So that really worked well. As well, we see in Pakistan, there's also resources with just manpower or infrastructure. And the local village politician said, yeah, I recognize it, but guess what? It's not my decision to make. We need to go one step higher and have that mandate down and the resources provided. As I understood, go along your perspective on it. And then we also touched base on taking a survey to schools and really looking at it in a small organization, a school, and getting to see how many children have vision health issues, how many actually need glasses, and then building that case up to the school administrator that these are your children that you should care to. And then another group took one step forward and brought it to the town administrator and the Minister of Health, Education. These these are all issues that your population is facing, and they actually then implemented targets that people were responsible for lowering that. So those are kind of the three big topics that learnings that we have.
Thank you, Michelle. That's great. And I love your 4 takeaways. And what really came through is that whoever you're advocating to at whatever level, you really need to think about what's going to be most relevant and what's going to resonate to them the most. And actually, when we're talking about advocacy and change, we're also talking about changing the whole system. And so taking account, as you said, as the whole ecosystem, who are the key stakeholders involved in this is critical. That sounds like a great discussion, and like you've got a lot done in that group. So who have we got next? So next, I think we're going to go to Rav and Aaron, who are looking at how you engage community health workers in people-centred eye care. Hi, Aaron. I don't think we can hear you. Hi. Oh, there we go.
Yeah. So Ravindra gave a detailed presentation about how his organization Seva functions. And through that, he had explained who are these community health workers, what's a Seva model of engaging them, and listening to their voices of the voices of the community through them. And he also spoke about this female community health volunteers who are very, very motivated, who are trained health practitioners, and who live in that locality and speak the local language, and they have good network with all the people living there and available throughout the year anytime. And they are connected to all the people in that community. And other with these female healthcare volunteers, he also told about the youths who link between the
Have we lost Aaron, or is it just me?
No, I think, yeah.
He's frozen.
He's having problems with his Wi-Fi.
Okay, let's give him a minute, see if he comes back.
I think he's mute.
Aaron, I think you're back, but you're muted.
I'm sorry. How Seva engages these female community healthcare workers who are the link between the organization and the community, and they talk for the community back to the healthcare workers and provide the required information required for the advocacy and the healthcare programs. And based on this, the organization also plans accordingly. So this is just a brief outline, maybe or more ideas of what he would plan, and also Simon also.
Oh, we've lost you again, Aaron. Can you hear us?
Sorry?
Ah, are you back? I think you've frozen.
Yeah. I think I have shared whatever we have discussed in the room, and I will ask Ravindra or Simon to add on more whatever we have discussed in that room.
Great. Ravindra, Simon, is there anything that you would like to add?
I think, thank you, Jess. I think Aaron's covered it really well. Really what Ravindra was covering was Iris had spoken about the listening element, listening to the community voices, and then what Seva is emphasizing in their program is then creating that link from the community to the level of advocacy. It seemed that in the particular environment where they were working, that link wasn't there, and so they created that through their youth volunteers, and that way they were able to listen, to capture that vast amount of knowledge that is held with community health workers, that knowledge which is very different to the knowledge that's held elsewhere in health systems at the other levels of health services as well. And importantly, they could tap into that knowledge, and then they could communicate that relevantly and appropriately where needed, and to policymakers in their advocacy program. So, yeah, so that was really well conveyed by Ravindra, and thank you, Irene. I think you covered that.
That's great, and obviously that's ultimately what is at the heart of the new model proposed by the World Report on Vision and Integrated People Centred Eyecare is putting people right at the heart of the eye care system, and it is going to take, you know, a fundamental shift in the way that we operate, not just in terms of our advocacy, but in terms of delivery and our programs for eye care as well. So really interesting to hear that model and to learn from Seva's experience. So our final group was led by Brandon. Brandon, you were looking at taking all of this and putting it into action. How did you get on?
Thanks, Jess. I feel as though we really just scratched the surface in our, 12 to 15 minutes or so, but it was a really good conversation, I think. We were really looking at trying at the action side of things, and how do we harness those patient voices, those consumer voices, or voices of others in the community like practitioners. How do we harness that in actually doing advocacy, implementing advocacy plans and those sorts of things? And we had a really good introduction from Megan Weber from Know the Glow Foundation, and she really gave us a powerful example from her own experience with the child with Coats disease, and what she had done to make sure that her son had actually access to care. But she's gone way above and beyond and trying to create awareness around Coats disease itself. So, in the short time that we had, we really looked at sort of examples where people could share, where consumer and community voices have been in play, and then some of the actual actions that have taken in place. So a couple of the examples in the UK, for example, was creating spaces for those with lived experience of macular disease or glaucoma through different events, community events, where people can come and hear, and those voices can be shared, and those experiences can be shared with those in the community, so they can learn what it's like to live with AMD or with glaucoma. And also there was part of that was also about for others who may be new to those conditions, can also hear from those with those experiences who have gone through sort of the ups and downs and the challenges. I thought that was really powerful. Another example was really about walking in the shoes, creating opportunities for people to walk in the shoes of those with a vision impairment. A good example of how to do that, and it's really quite simple, is having those simulator glasses for teachers. So they can actually put on a pair of these goggles that simulate cataract or glaucoma or refractive errors, and try and read the board. And it gives them a real experience of what it's like for their students. And I think that's a really powerful example of how to put somebody in the shoes of somebody with lived experience. Another really good example attached to that was for practitioners to be really proactive about bridging gaps between sectors. So, for example, between the hospital or healthcare system and education. So optometrists as actors going into schools and teaching screening with teachers and other educational workers. So it's really about trying to be proactive and bridging those gaps. In terms of the actions, there's sort of a range of different actions that came up and types of mechanisms of how we do advocacy and creating those those spaces for those voices. A really good one, which was in speaking to decision makers, those who have the power to make decisions, asking them to reflect on their own personal examples of their mother or their father or their grandmother, who may have lived with or living with a vision impairment, and asking them to reflect on what that experience looked like. So I think that's a really nice example and quite a simple one that sometimes we overlook. Right throughout the conversation, awareness is really, really key. And Megan's example I mentioned before was a way of doing that, sharing those examples and creating that awareness so people can see what can be done. There's also a point about for decision makers, you've also got to speak in their language. So you know, we also need to make sure that we speak in those economic terms. And again, we're having a fairly broad approach to those community voices. So the economy is one of those voices, and the actors in industry and employment are another actor to provide that voice around the economy. You can also engage those in the community who go out door knocking and those sort of things. For example, female health workers in Pakistan, and empowering them with the skills and information about blindness and vision impairment is really important. We can develop community ambassadors. So, and that's a sort of a proactive action in giving people with lived experience skills to speak to decision makers, to speak in forums and so forth, to share their own experience. And attached to that, it's about, you know, we can create a whole range of different opportunities through different types of media, through visual arts, through photos, through case studies, and having them, for example, in hospitals or sharing them with decision makers in parliament or ministerial offices that really bring those stories to life. So there's lots of different ways we can do that. And that's really all we managed to get to in our time. Thanks, Jess.
Brandon, if that's scratching the surface, I don't know what your group would have come up with if we had given you the full hour. I mean, that is some really great practical suggestions there, and a lot for us to take away. I think from across all the groups, I should say, you know, none of this great work will now, it'll all be put to good use. And we'll collect all of this information up and use it in our advocacy efforts as IPB, but also share it more widely across the whole sector. So thank you very much, everyone, because I think it was a really rich discussions in all of your groups. What I would like to do now is just to ask all of our presenters and speakers, but also all of you in the audience, to think about how IPB can support this agenda. How can we promote, engage, include community voices in the work that we're doing, and support all of you to do the same. So I'm going to come to each of our presenters and speakers and ask them just to give suggestions off the top of your head in sort of one line, a couple of sentences. But while we do that, can we also ask the rest of the audience to pop any ideas into the Slido? And I don't know whether the team can bring up the Slido again so that we have that. Because I think, you know, there was so much there in the discussions, and we want to now use that to take the next step into building it into our program of work. So I'm going to start with Michelle. Can we come to you first? Do you have any thoughts about how IPB might take this forward?
Yeah, no, thank you. Yeah, so first, right? I would suggest that the IPB, being the kind of organization that it is, that it's really about providing how to do kits and copy with pride opportunities and sharing best practices with what's being worked. And I know it's harder, it's easier to say than do because nobody really is able to capture it. But just hearing from the examples in the second workshop about the two survey collections, data analysis surveys, and then seeing how far they could take that to really change practice, others can easily adapt that. So my call to be provide templates, context, and best practices people can copy with pride.
Thanks, Michelle. Great suggestion. And we can use a lot of what was discussed here today to help populate that. Avril, let's go to you next.
I think a couple of things. First and foremost, what you have is a very broad group. So this might sound a little bit contradictory, but I think it's about looking beyond your network. You know, looking beyond the network, I think, is important because the people you think will be all together with a common goal towards a particular end may not necessarily be the same people that you expect when you get to the finish line. And I think we all have to do that. So I would say, look beyond your network and really listen to the various different cohorts, because, you know, in listening to the discussions at our session, you know, the issues that I'm dealing with in Dublin and Europe are so entirely different to the issues that are being dealt with in China, as was the example in Nicaragua and in Kenya, you know, that how do you deal with these issues? So I think that look beyond, ensure that we're all aware of these issues that affect many, the broad community. And then just again, it's getting back to the listening, the really listening, to learn how these gaps affect people on the day-to-day basis, and then we can lead the change together. And I think what's very important and what IAPB can really do, because of the breadth of your remit, is to bring us together so that we are aware of the way ophthalmology is positioned globally, not just our particular areas, but ophthalmology in general. And I think that would be a great help to all of us so that we can support each other wherever possible.
Thank you, Avril. No, completely agree. And a lot of the comments actually that are coming through on this Slido definitely reflect that. We need a place to bring all those perspectives, but also those invaluable learnings and approaches, you know, all in one place, so that we can look at it holistically across the sector. Let's go to Ravindra now.
Yes, thank you, Jessica. One of the missing, puzzle in our advocacy is using our young people. In the whole eye care sector, we sometimes ignore the role of the young people in the whole process. If we engage them, you don't need to become the experts. They can be the enablers. They can be the people who can, link from the community to the, service provider to the, policy makers. So it's very important that we actually engage those young people because they are the ones who can be, mobile, who can, go reach to the, communities very easily, and they are very enthusiastic. They are very, dynamic, and they are very, cost effective as well. So so maybe, we should try different models. This model that we tried in Seva, Nepal, we demonstrated that, model, and we proved that, this is a very, useful model. And I think, this is something that, we should, we can try. Basically what I would like to suggest to IAPB is to try different models, and youth model can be one piece that, we can try. And I think it gives a very good result overall in our eye care services. Thank you.
I completely agree, and particularly about engaging young people. Our eye health heroes, some of whom I think are on this call today, is just a testament to how enthusiastic but also powerful young voices can be in advocacy. So thank you for that. Let's go to Iris next.
Thanks a lot, Jess. So what I, again, want to stress is the listen, learn, lead. I know I said it a few times today, but I think that IAPB can really try, as Avril said, to start listening or listen more to maybe other organizations, associations, and include maybe other stakeholders, listen to them and learn from them to make sure that whatever you do is really supporting the needs of the people that you want to serve. So including the patient community voice and listening to them, that's something that I would recommend.
Completely agree, and I really like listen, learn, lead, and this is, I think this session is the first step in the listen, learn, lead, and I hope will be the first of many steps that we take as IAPB. So this is definitely not the end in terms of what we have planned for this going forward. Can we go to Aaron next? Oh, Aaron, you're on mute, I think.
Sorry.
Oh, you're muted again.
I would like to share the same opinion like Ravindra and other speakers, like the community voices are the main, these are main.
I think we've lost Aaron again. Okay, let's come back to Aaron. Brandon, can we come to you?
Thanks, Jess. And, you know, everything everyone said is fantastic. I think I want to sort of confine my comments to the group of people which I'd call sort of those with lived experience of blindness and vision impairment. And I think when we talk about IAPB, there's IAPB, the organization, but I also think IAPB, the royal we, which is us as members as well. So two things. One is we need to be proactive in engaging those voices. And the second thing is we need to be inclusive in how we talk about those in which we are serving. So to be proactive, we need to create those spaces and the mechanisms for those voices to be heard throughout the whole process, built in from the beginning. So again, we need to find and create those spaces proactively. And to be inclusive, that's really about saying that we need to make sure in all our communications and how we talk about people who are blind or vision impaired, we need to make sure that we're not speaking about them as they and other. We need to use language which actually brings them into the tent, and so they feel included. I think that's really important because, and that gives us integrity in bringing those voices to the fore. Thanks, Jess.
Thank you, Brandon. And I'm very pleased that you use the we as all of us as IPB, because I think that's absolutely right. We're all advocates, and we need to stop, pause, and think about who we're advocating for, who are our community, who do we all serve as advocates, and recognize that we're all responsible, as Brandon said, for creating that participatory space to enable those voices to come through in the work that we're doing. So I hope that that's something that we can all take forward. There's been a huge amount that's come through on the Slido, so many fantastic suggestions, really practical suggestions as well. And I think just throughout this session, there's been an enormous amount of invaluable kind of recommendations and thoughts from across the audience, and so we will definitely put this to good use, and we'll bring it all together and share something with all of you after this session. I think I'm going to bring today's session to a close. Thank you everyone for joining, but also for participating so actively today. And of course, thank you to our fantastic presenters and moderators for all their work. Just really to leave with you and say that our next session will be a workshop again, so we'll put you back to work in the next session on the 7th of December on building effective policy dialogues. So again, all of the information and the materials for that session will be available on our website. Thank you always to our fantastic sponsors of Advocacy to Action, without whom this wouldn't be possible. And I hope to see you all at the very last session of the year. Thank you, everyone.